Hi there, thanks for having me. Let's talk veins. Quick question for you. Do you have any of the following lower extremity symptoms? Pain, swelling, aching, throbbing, heaviness, fatigue, night cramps, restless legs? Do you have varicose veins? Do you have skin changes or a non-healing ulcer? I'm hoping that after this talk we can do this poll and see what the results are looking like. If you are watching this, there's a decent chance you are a healthcare worker, so I thought you might be interested in a fairly recent study that was designed to measure the prevalence of and risk factors for the clinical manifestations of CVI and ultrasound evidence of venous reflux or obstruction in healthcare workers. They had a total of 630 participants in a large hospital institution where they offered free screening and education to all of their employees. They collected demographic information, medical history, whether or not people were using compression stockings. They did a SEEP score, ultrasound exam, and a Caprini score to evaluate the risk of DVT. Results, at least to me, were somewhat shocking. 82% had venous reflux disease, almost 70% had evidence of CVI, 14% were at risk for DVT. And we're going to talk a little bit about the difference between venous reflux disease and CVI in just a little bit. First, let's go over some definitions. As you are all likely aware, venous reflux occurs when a valve becomes incompetent and allows blood to flow in the wrong direction in veins. Venous reflux disease refers to patients that have venous reflux demonstrated on ultrasound but do not have swelling or skin changes, whereas CVI, patients have both venous reflux and swelling, skin changes, or ulcer. In other words, CVI is more severe than VRD. Few more definitions. Spider veins, also known as telangiectasia, are by definition less than 1 millimeter, while varicose veins, as you know, are greater than 3 millimeters. People often get confused about what are reticular veins, which are also called feeder veins. Those are the veins that are 1 to 3 millimeters in diameter. The reason we call them feeder veins is we see them feeding spider veins. Lastly, to fill out the definitions component of this talk, we should discuss the SEEP score, which it was developed in 1994 and recently modified in 2020. This SEEP score was developed in order to standardize the reporting and treatment of the diverse manifestations of chronic venous disorders. Let's focus our attention on the C component of the SEEP score, which ranges from C0, which is normal, through C6. C1 refers to patients with spider veins, C2 varicose veins, C3 edema, C4 skin changes or corona phlebitictica, C5 a healed ulcer, C6 an active ulcer. Quick quiz question for you. Patients with varicose veins have a quality of life score similar to patients with prior MI. True or false? And I'm sure you all guessed true. So yes, this is a true statement. Patients with varicose veins have a quality of life score similar to patients with prior MI. Not only that, but femoral neck fracture and stroke. And it's even worse for those with venous leg ulcers who have quality of life scores comparable with heart failure and COPD. Now you might be wondering why I started with a poll regarding these symptoms. Well, these are symptoms of VRD or CVI, and you are all healthcare practitioners. And I want you to keep in mind the results of that healthcare worker study. Nearly 70% of those studied had evidence of CVI. And let's not forget, CVI is pretty severe. These are individuals that have venous reflux with swelling, skin changes, or ulcer. So, we know that vein disease is common in healthcare workers, but let's put this into perspective. Which of the following has the highest prevalence in the United States? Cardiovascular disease, diabetes, chronic venous disease, and peripheral arterial disease. And you likely guessed correctly that chronic venous disease is more prevalent than cardiovascular disease, diabetes, and peripheral arterial disease combined. In fact, about 25% of people in the United States are affected by venous reflux disease. So that accounts for over 30 million individuals. Another way to think about this is that for every 4 patients that walk into your office, at least one of those people are affected. Now, out of these 25% of individuals, or over 30 million people, about 17% are diagnosed, but only 1% are actually treated. Now, before we talk about the potential benefits of treatment, let's talk about the most common treatments and how they're done. The treatment concept is that varicose veins like these are caused by venous reflux. So if we ablate or close down the incompetent vein, we can get results like this. So graphically, this is how things work. Now, these veins are not drawn to scale. The veins on this diagram are just supposed to illustrate the superficial venous system, not the deep system. So the arrow points to great saphenous vein reflux. You can see the arrows facing downward, leading to varicose veins. So venous reflux is the cause of varicose veins. What we do then is we want to close the unhealthy vein down. So we place a catheter, in this case an RFA catheter, into the unhealthy vein. The heat closes the unhealthy vein. And then, as you can see in this diagram, blood is rerouted to healthy veins after the ablation. And notice that there are no varicose veins because now the blood flow has improved. This is the ideal situation and doesn't occur all the time. So I'd love to spend time and talk about all the tools in our toolkit when it comes to endovenous ablation options, but just know that we've got a couple of thermal options, that being laser or RFA, and then we have a slew of non-thermal techniques in our arsenal. The advantage of these non-thermal techniques is that they require fewer needle pokes. Why? Because when we're doing thermal ablation, we have to numb up all the tissue surrounding the affected vein. The newer techniques that don't use heat don't require that anesthetic. With the non-thermal techniques, since there's no heat, there's no chance of skin burn or nerve damage. In terms of the results are overall very similar. I do want to just mention the newest ablation technique we have, which is Venous Seal, which takes advantage of a medical adhesive. The way we do the procedure is first under ultrasound guidance, we place the catheter where we want. We then deploy an aliquot of medical adhesive, pull the catheter back, compress the vein. The glue causes the vein to stick together. Like I was mentioning, in the perfect world, simply closing down the unhealthy refluxing vein would basically get rid of all varicose veins. Reality is that doesn't occur. It occurs sometimes, but not all the time. So in a patient like this, we have adjuvant therapy, microphlebectomy, and sclerotherapy. Let's just talk a little bit about microphlebectomy. Tools of the trade are very simple: a blade or a needle, a hook, hemostats. Here's a close-up of the hook. And this is what we can expect to get out of a patient like the picture I showed you. Notice that these veins were removed without any sutures and there was no bleeding. That's how we can get a result like this after only one treatment. Another quiz question for you. Which of the following is the most common cause of lower extremity edema in the United States? Lymphedema, CVI, congestive heart failure, pulmonary hypertension. And you likely guessed CVI. There are other things to consider in the differential diagnosis. We've mentioned CVI, lymphedema, lipedema, medications, systemic disease, and dependent edema. It's really important to keep in mind that venous reflux may coexist with all of these. Let's spend a moment discussing lymphedema. Here you have all the evidence you need to make the diagnosis of secondary lymphedema, which is far more common than primary lymphedema. You can see the pillow-like swelling of the foot and the sausage-like appearance of the toes, so you get the diagnosis of lymphedema. You can also see a surgical scar. So this is a patient, a good example of secondary lymphedema. So what are the causes of secondary lymphedema? CVI, obviously the most common. Obesity, because it is an epidemic in the United States. Worldwide, infection and inflammation are probably the most common cause. Other things to keep in mind: tumors, surgery, trauma, radiation, really anything that can damage or obstruct the lymphatic systems. Primary lymphedema is much more rare. It's about 10% of lymphedema patients. It can be separated into 3 groups based on age. Most of the patients that we see are of the tarda version, although we have seen an occasional teenager. Quick word on lipedema. Lipedema is a loose connective tissue disease that's seen predominantly in women. It's characterized by increased nodular and fibrotic adipose tissue on the buttocks, hips, and limbs. Of note, it spares the trunk, feet, and hands, and that's why it gives us this classic ankle cutoff sign, where the leg is big, and then once we get to the ankle, all of a sudden the foot and toes look normal. Keep in mind that lipedema tissue can be or may be very painful, and that's due to inflammation, and can severely impair mobility. So we talked about chronic swelling, and that is really what presents the biggest dilemma to most clinicians. But I think it's important to always keep in mind, what about acute swelling? So most of the times with a careful history, physical, and sometimes imaging, the diagnosis is pretty easy for clinicians to get to. I think the take-home message here, though, when dealing with acute swelling is DVT until proven otherwise. Another quiz question for you. What percentage of leg ulcers are venous in origin? And I'm sure you guessed choice D, 60 to 80%. When I'm talking to patients about leg ulcers, I like to use the drywall analogy. So a hole in the drywall is similar to a skin ulcer, the skin being the drywall. And of course you can just patch up the drywall, but if there's a leaky pipe underneath the drywall that's the cause of the hole in the drywall, just patching up the drywall isn't going to work. And the same analogy can be made to the skin. For those of us treating veins, we saw the effects that endovenous ablation had on ulcers, but we really needed the scientific proof. And a study in the UK did just that. They randomly assigned 450 patients with venous leg ulcers into 2 groups. The early endovenous ablation group, just like it sounds, they received endovenous ablation on diagnosis along with standard compression therapy, whereas the deferred group, endovenous ablation was deferred until after the ulcer was healed or 6 months after randomization if the ulcer was unhealed. Early ablation resulted not only in faster healing of venous leg ulcers, but also more time free from ulcer following treatment. So endovenous ablation techniques have really replaced surgery, and they function as an adjuvant to standard compression. So standard compression is still a mainstay of treatment, but ablation certainly helps quite a bit. So what have we discussed so far? Vein disease is common, especially in healthcare workers. Quality of life is severely affected. CVI is the most common cause of chronic lower extremity edema, and most leg ulcers are venous. Now, a common question that we get in the office, we see many elderly patients who have osteoarthritis. So they require orthopedic surgery. So the question we receive is, which should come first? So there was an interesting study done on the usefulness of prophylactic treatment of GSV insufficiency in elderly patients undergoing orthopedic surgery. And they retrospectively looked at 44 patients over the age of 65 that were going for total knee or total hip. So these patients had both CVI and osteoarthritis. The chronic venous insufficiency was treated prior to the orthopedic surgery, and then DVT in this group was compared to reference works. Results? 50% decrease incidence in postoperative DVT, something that I was actually somewhat surprised about. Okay, so we talked about the procedures in those over the age of 65. What about the octogenarian group? So another common question that we get from our patients or patients' family members is, hey, mom or dad, they're in their 80s, are they able to undergo these types of procedures? So there was a study done on 362 patients, and they separated this group of patients into 3 groups based on age. Those less than 65 years of age, 65 to 79, and those greater than 80 years of age. It's important to keep in mind, as you might guess, in the octogenarian population, they're more likely to have cardiovascular comorbidities. These are sicker people. They're more likely to have advanced venous disease as determined by the SEEP score. So what were the results in this study? No significant difference in clinical success, technical success, or complications among the 3 groups. The author's conclusion, venous ablation is safe and effective in all age groups. Age should not be used to deny patients ablation. Another quiz question. A patient with a cluster of spider veins around the ankle most likely suffers from scleroderma, rheumatoid arthritis, CVI, or hypertension. Like we mentioned earlier, this is corona phlebiticata, a sign of CVI. And here is the revised SEEP classification, and you can see that corona phlebiticata is now part of C4. A quick case study, 35-year-old female with throbbing, pulling, and creeping in the legs with an uncontrollable urge to move them. Symptoms are worse at rest and at night. She's a very, very active individual. Physical exam, completely unremarkable. What's your diagnosis? Restless leg syndrome. So the hallmark of RLS is there's an uncontrollable urge to move lower extremities primarily at night when a person is relaxing or at rest. Because individuals affected have the need to move their legs, it's classified as a movement disorder. Estimated to occur in up to 10% of the US population prior to medications. Venous reflux workup is really indicated. And why do I say that? I say that because venous reflux is a cause of RLS, but it's a treatable cause. When we see patients that have venous reflux and restless legs, about 70 to 80% of those people are going to improve. Either they can stop taking their medications, or they don't even start medications, or for some people, they can get enough improvement that they can at least decrease the dose of their medications. There was an interesting study done fairly recently on sleep disorders. A retrospective review of 540 people in for sleep study found 40 patients with RLS. Of those 40 patients, 20 were found to have CVI. Author's conclusion based on that, even though the numbers are small, CVI may be the underlying cause in a significant number of patients who are thought to have primary RLS. CVI should be investigated in those with an RLS diagnosis. So let's wrap things up. Healthcare workers are at risk for CVI. Chronic venous disease is extremely common. Remember that for every 4 patients that walk into your office, probably 1 patient is affected. Let's not forget the severe effect on quality of life. C2 through C4 non-ulcer patients, quality of life scores are similar to patients with MI, hip fracture, and stroke, and things are even worse for the ulcer patient. Remember that it's helpful to treat varicose veins before a total hip or total knee. CVI is the most common cause of leg edema and ulcers. Early ablation is helpful in the treatment and management of leg ulcers. It's safe to perform venous ablations in the octogenarian population. And before putting a patient that has restless leg syndrome on medications, it's really important to get a vein workup. Thanks so much for listening, and I look forward to chatting with you at the Q&A.